Good morning. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Families in Crisis, Working with Families in Recovery. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and to me, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send any questions you may have as you think of them, and the presenter will answer questions during the presentation as time permits. Our audio is being broadcast through the internet to your computer. You must have speakers attached to your computer and have the correct software and the volume on. However, if you do experience poor computer audio, there are a few options to try on screen right now, and these options are posted in the chat panel too. If you continue to experience a loss of audio through your computer speakers, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio portion of the presentation and view it on screen to receive your statement of credit. The recording and materials used in today's presentation will be available on the FADA website within 5 business days. Also, a PDF version of this PowerPoint presentation will be emailed to participants also within 5 days. As many of you know, FADA produces many webinars and workshops throughout the year through the support of the Florida Department of Children and Families. To help participants track credits that have been earned through attendance, we have launched a new website that provides a personalized digital journal where participants can maintain statements of credit for every webinar and workshop taken through the Florida Alcohol and Drug Abuse Association. So at the conclusion of today's webinar, as usual, the web browser will direct everyone to an evaluation form on the FADA website. You will be prompted to register or log in to complete the evaluation. Once you do register and complete the evaluation, you'll be able to access a statement of credit right within your member profile. Keep in mind that any information you provide FADA as part of registering does remain confidential. Also, as usual, completing the evaluation is necessary in order to receive continuing education credits or to access your statement of credit. And do note that the evaluation for today's webinar does close at midnight on Monday, April 16th. Approximately 1 to 2 continuing education credits are available for participating today in the webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license number for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside the state of Florida, you do not need to provide your certification number when you register with our site. Please note that WebEx monitors arrival and departure of attendees and provides us with a report upon completion of the event. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar, and we are not allowed to provide partial credit. I'd like now to introduce our presenter for today's webinar. Gabriela Zapata-Alma, LCSW, CADC, brings over a decade of experience providing direct services, training, and consultation, as well as designing and leading programs using motivational interviewing, harm reduction, trauma-informed care, housing first, and third-wave behavioral interventions. Gabriela graduated from University of Chicago's School of Social Service Administration, earning certifications in evidence-based practice and advanced alcohol and other drug abuse counseling. Gabriela has presented locally and nationally on a range of topics specific to serving highly vulnerable and medically complex populations, and has provided consultation and technical assistance to programs serving homeless individuals, families, and youth with co-occurring disorders locally, nationally, and internationally. And we're very pleased to have Gabriela Zapata-Alma join us today. And Gabriela, if you're ready, I'm going to flip over to your presentation and turn control over to you.
Perfect. Thank you so much, Leanne. Good morning, everyone. I'm so happy to be joining you. I'm calling in from Chicago, where it is 55, which is much nicer than the snow that happened a couple days ago. But I was just in Florida last week, and it was so gorgeous. The sunshine was just amazing. I had the opportunity to provide some trainings in Florida last week. You'll see in the chat box, you have the ability to click a button, which is the raise hand. If you happen to attend one of my trainings last week, could you just go ahead and raise your hand so I can see how many of my newest friends have joined us today? Great. Oh, wonderful to see you. So happy to be with you again, even though it's from afar. So you'll see in the chat box, you have the ability to kind of type in and then send to. There should be a little, you know, we want to make sure that we're sending it to all participants because today is going to be really interactive, and I'm going to be asking you to participate and kind of give your input throughout the webinar. So definitely not a passive webinar. So as we move forward to our learning objectives, so some of the things we hope to accomplish in the next couple hours: review the continuum of family involvement and treatment, learn about some evidence-supported strategies to engage families, particularly through psychoeducation, and then finally become familiar with the basic components of craft therapy, which can be a really great resource in engaging individuals into treatment through their family members. If folks could go ahead and type in the chat box, I'd love to see how many folks are joining us that are substance use counselors, or, you know, child advocates, or maybe family providers, you know, kind of what your role is in helping families through recovery. So I'll give you a couple moments there to start kind of typing into the chat box. Family wellness counselor, children's case management supervisor, child and family therapist. Care manager, long-term recovery specialist, mental health and addiction nurse, integration coordinator for behavioral health and child welfare. What a beautiful title. So needed. Great. Well, thanks, everyone. So first, I'd love to hear from everyone kind of what you put as a word or couple words completing this sentence. Families are. So kind of off the top of your head, go ahead and enter in the chat box. What comes to mind when you think families are? Complex, important. Another one for complex. Very important. Resilient. Oh yeah, we got a couple there for resilient. Challenging. Vital to the recovery process. Families are love. A complex unit that has many facets. I love how you talk about that it's a unit. Families are our primary community. Families are unique. all different, invaluable to success. Great. And so digging deeper, what makes up a family? So how we define family is largely rooted in culture. When we look at cultures that are more individualistic versus more interdependent, there can be a really a wide spectrum of ways that we move towards defining family, that we shape our family, that we perceive family, family connections. You know, thinking about my own history as a Latin American person, thinking about how all of our close family friends were really considered part of our family. And then seeing how, you know, raising my son in the States, how that can be a little bit different here. And so for us as practitioners, one of the most important things that we can really do is elicit and support the person in care as defining their own family. How do they see their family? Who is kind of within that family? What is the family unit? What is more extended family? What is their chosen family? That for many individuals, family might not just be about blood or legal relations, that it's really about a way that they, a level of interpersonal intimacy and support that they enjoy with their chosen family. So I'd love to hear from you. How do you elicit the person's self-defined family? And how do you go about assessing for a person's chosen family? So go ahead and type some answers in the chat box. A verbal social history. Who do you turn to when you need to talk? Oh, I love that question. Who they prefer to spend time with, who they confide in, asking them who they consider to be their family. Who's your support system? Listening. Active listening. Such an important part of the work we do. Who is your identified support system? Who is in your support system? Absolutely. Who have you turned to in the past for support? I love all of these descriptive questions because so often if we ask, tell me about your family, many times people are going to assume that we are only talking about, kind of their legally defined family, which is important information, and yet we may be missing out on a whole support system that may not just be rooted in kind of the legally defined family, but it might be a missed opportunity for us really finding out who that person defines as being within their family. So I want you to think of a person you're serving. So think of someone on your caseload, or maybe if you're a supervisor, someone who's being served by your program. And I want you to consider and reflect on, does their family influence their substance use? Some more specific questions might be, is there a family history of substance use? How do family relationships or dynamics act as cues for people to use? And how does the family build or reduce their motivation for recovery? A lot of things that people think is support can many times drive shame and guilt and then drive use for a person. So how does the family build or reduce their motivation for recovery? So as you kind of reflect on those questions, I'd like you to type in the chat box, what are some ways that you've addressed these issues in the person's recovery plan or service plan? Now I want to highlight that if, so use the chat box and send to all participants for anything that, any questions I'm bringing up. If you have a question for us, go ahead and put it in the question and answer box, because then we can make sure that we see those questions. Encouraging teens to ask their parents about their parents' recovery and what has been helpful for them. Wow, so really leveraging that, the strengths of the family and the family history.
And Gabriela, this is Leanne. Let me just clarify also that our participants today, they are not able to see what everyone else is writing. Just so you're able to see that and I'm able to see that, just so you know.
Got it. Thank you, Leanne. So then I'll be sure to kind of say it out loud as people type in so we can hear from each other.
Wonderful. Thank you.
Looking for risk and resilience factors. Assisting in setting up family meetings to encourage communication and togetherness. Yeah, we can play such a vital role in helping to really improve the family communication, the family coping skills, and increasing their togetherness. Really looking at how the family has tried to help them in the past, as well as looking at how the family might present a challenge to the person's recovery. And so in their recovery plan, really looking at the individual strengths maybe to deal with some of those challenges brought on by family. Yeah, and that it really needs to be individualized. Everybody's recovery and recovery needs are really personal. Looking at how would you like to be supportive to your children. Looking at healthy family boundaries. We know a lot of times families may have boundaries that are too rigid or, on the other side, too diffuse. So looking at kind of what is healthy boundaries for that family and for that family to move forward in recovery. Yeah, you might, in the service plan, you might provide referrals to drug counseling to really enhance the substance abuse education that's provided in the home. Providing family therapy. Yeah, substance use is a family affair. So whenever we're able to engage the family in therapy, that can have a really big impact on recovery. Great, thank you everyone. So looking at family systems. Family systems theory tells us that a change in any part of the system will impact the entire system. And so there can be a lot of different changes that we see, developmental changes of the individual, as we know that family relationships change as individuals develop, loss of family members, as well as gaining family members, as well as shifts in relationships. We also know that families kind of have their natural homeostasis, that families in a way kind of have their own rhythm, and when there's an impact on the family system or there's a change in a member of the family system, it's almost like that system will then try to counteract that change sometimes in order to go back to their family, kind of their homeostasis, their established family dynamic. So we see this sometimes where as one member of the family starts to get healthy, another member of the family may become sick. And then the family starts to take on kind of a caregiver role to that family member. We also have seen how sometimes somebody may be making progress in their recovery, and it's so unsettling for the family because it's not what they've known, it's not what they've been used to, that they may actually end up sabotaging the person's recovery. And a lot of this happens very unconsciously. It's not outright malicious by any means. But we've seen, individuals who are in early recovery, maybe, 3 months sober from alcohol, and a family member brings home a bottle of alcohol to say, oh, you've been doing so great, I thought that, we deserve to celebrate. And from their viewpoint, they're doing it from a place of support, and yet we know that this is actually a way that family homeostasis is showing up in kind of an unconscious way, trying to drive back to that dynamic. And so we know that the impact that we have in a person's life will kind of have that effect in their family system. And so with that knowledge, looking at what we can do to support the family system to really move forward in that healthy change. And then looking at family systems, knowing that subsystems are embedded and operate within the larger system. So this means looking at the dynamics that may exist between couples, parent to child, siblings, extended family, chosen family, communities, cultural faith communities, and then how gender dynamics exist within those systems, as well as dynamics around kind of who's the decider, who gets to have a voice within the system. Is it more of a hierarchical kind of authoritative decision, which it is very healthy for parents to be the ones who are making decisions, but is it rigid to the point where, children don't have a voice or their needs aren't taken into account? Or is there more of a bidirectional flow between the different hierarchies? So really looking at all of that. And those of you who work within the home and are able to do home visits, I saw some comments about, being able to observe the family dynamic within the home, and that's absolutely right. There's something that's so powerful about working with families is that when you have family members in the room, even if it's not the full system, you start to see what's happening versus just hearing about what might be happening. We're able to have such a greater impact when we see kind of it happening right before our eyes. And then also from there, looking at the subsystems, but also looking at that families exist within a larger social environment. So here is one potential model of how to conceive of that. So looking at the family and then friends, extended family, neighborhood, church, school and workplace, expanding out from there, potentially legal system for those who may have some kind of legal involvement. Ethnic and cultural systems are really pervasive throughout all levels of the family and the family embedded within the larger social environment. Health and mental health services, human services, and then of course greater society and history, that we all exist within our own social cultural history. And that knowledge of that history is passed down through generations, and that's what in many ways shapes culture and how culture is passed out through generations. So there are some barriers to kind of looking at integration of substance use and recovery and more of a family systems approach. So whenever we're looking for greater integration, it's important for us to know what are some things that we may not even realize are kind of differences in how we approach the work and how we define the scope of service and who we're serving and how we can impact and intervene in order to help the client move forward. So on the left-hand side, you see family therapy and kind of family systems theory. On the right-hand side, you see substance use treatment. So in family therapy, we often see that the family system is the client. And so we view the substance use disorder as a symptom of the family dysfunction, that many times it is through the person that is expressing the family dysfunction through their symptoms that kind of comes to the attention of helping professionals, but that we see that as kind of the tip of the iceberg many times. And so with that viewpoint, we put the family's recovery at the center and look at and theoretically see that the individual will recover as a result of the family's recovery. And so in this way, largely attends to the process of family interactions. So you can see how family therapies and family systems theory really puts the family at the center of the work. And historically, traditional substance use treatment tends to really focus on the person who is presenting for treatment, and puts their individual recovery above all other needs and goals. Now, this is something that is starting to change as more and more treatment centers are seeking to practice gender-responsive services. As we know that treatment for women, many times their pathways into substance use is relational, and their recovery is very relational. So this first bullet point is starting to soften with a lot of kind of women-dedicated treatment centers, and yet it's still, I would say, where we come from in substance use treatment, and many times kind of the pervasive approach in substance use treatment. And in this way, because of the laser focus on the individual, what ends up happening as a byproduct is that we can disregard the needs or experiences of family. And then, of course, we also have a lot of laws governing confidentiality. Rightfully so, confidentiality is extremely important in this highly stigmatized disorder, and yet that in and of itself can be a barrier to consider how to work with confidentiality while also engaging people's family. In substance use treatment, we see the family as impacted by the individual's substance use and substance use disorder rather than the family as kind of part of the picture of the substance use disorder. And so in this way, classically, we tend to try to support the family largely through psychoeducation versus family therapy. But we're gonna take a deeper dive into the continuum of family involvement. So here we'll look at the continuum of from solely individual focused to fully family-based treatment. And for those that are joining that aren't necessarily in the substance use treatment role, this can be really valuable information as you build the person's service plan and as you provide those referrals to treatment. If you're able to assess whether, okay, there's some pretty deep family dynamics happening here, and so I'm going to make a referral to a treatment center that I know is going to be have a larger focus, or at least services available for family treatment versus working with somebody who you can assess doesn't necessarily have a need for more family-based services, and so then referring to more of an individual-based provider. So level 1, counselor has little or no involvement with the family. So here what we see is that the counselor may contact the family for purely practical reasons. It might be coordinating transportation, it might be to gather maybe some more history, and here we really see the individual as the only client, and because we have that unconditional positive regard for the people we serve, and because we always endeavor to serve them to the best of our abilities, in this level 1, sometimes we even see the counselor feeling a little protective of the client. So really feeling like they need to protect the client from the family. Versus, on the other hand, taking a step back and seeing how the family dynamic impacts kind of everyone in the family and taking it more as a matter of fact versus kind of taking sides. Now, I also like to talk about level 0. Level 0, I would say the counselor has zero involvement with the family and is not even getting any kind of family history throughout their, comprehensive psychosocial assessment. So while that is not kind of a defined level of the continuum of family treatment, we sometimes see that play out in our services. So now, thinking about level 1, the counselor has little or no involvement with the family. Think about how often do you provide this level of services?
And Gabriela, this is Leanne. Would you like for me to open that poll?
That'd be great. Thank you, Leanne.
We're going to try this. So we're going to open a poll for everyone, and we'll see how it works.
Great. So folks can go ahead and click one of the buttons of always, usually, sometimes, rarely, looking at how often you practice at level 1.
We've got about 70 responses that have come in, so that's great, and more are coming.
Great.
And we have plenty of time, Gabriela, so just let me know when you want to close it.
Perfect. We'll give folks about 10 more seconds, and then we can close it. Great. Leanne, could you display those results?
Let's see what happens when I close the poll. We may need to do that before we can display, so let's just see what it looks like. Are you ready to close it?
Yeah, let's go ahead. Thank you.
And it looks like we've got about 10 seconds. A few people were in the process, so I think this system is waiting for those. 2 seconds, 1 second. All right, so Gabriela, let's see. We're going to share the poll results with the attendees.
Beautiful. Okay. So we have some folks who are always, majority more of a sometimes or rarely, and then a little under half no answer. So don't worry if you didn't get a chance to answer. We have some other polls coming, so you'll be able to answer for these other ones. Thank you so much, Leanne.
Of course.
So looking at level 2, the counselor provides psychoeducation and advice. So at this level, the primary focus is still the individual's substance use and their presenting factors around their substance use disorder, but the counselor is aware that it affects family relationships and that counseling will change the family dynamics. So here, while we still may be providing largely individual services, we do bring with that an insight and awareness. We're kind of keeping those ears open, that curiosity around how family relationships have been impacted by the substance use, and that family dynamics will likely change as the person engages in their treatment and makes progress in their recovery. So in this way, the counselor is open to collaboratively engaging and advising families, but for those specific family services, will likely refer out for any of those specialized family services. So here we're seeing that openness, that awareness. We're still not yet seeing that kind of, I would say, assertive engagement or active involvement within the family. So thinking about the level 2, let's go ahead and open up that second poll of how often do you provide level 2 services.
And we're open.
Great, thank you. So those that didn't get the chance to respond last time, here's your chance. Come on in.
And it's just been about 1 minute. So we might want to give it a...
How many responses do we have so far?
So far we have 87.
Nice.
And they're still coming in pretty quickly.
Perfect.
And I can close it whenever you're ready.
Great. If we can give folks 10 more seconds to get their answer in.
Okay, I'll watch it.
All right.
And there you go.
Perfect. Thank you. So we're seeing here that 20% usually respond this level of care. So really having that awareness and being attuned to kind of how those family dynamics may come up, how they might be impacted. And then we have some in the sometimes category. Thank you so much, everyone. So moving on to level 3. Here we see that the counselor addresses family members' feelings and provides support. So here the counselor is aware of normal family development and reactions to stress. So they already kind of have that background knowledge that goes beyond a knowledge of just family dynamics, but also understands kind of normal family development and stress reactions. And so here the counselor may empathically elicit and respond to client and family feelings and provide tailored psychoeducation. So not just maybe like more general brochures or pamphlets, but really thoughtfully seeking out information to provide based on the family and individual's needs. And here the counselor may also assess family functioning as it relates to the individual's use and is a little more active in referring to specialized services if needed to address the family's unique needs. So in looking at this level, where would you place yourself in kind of always, usually, sometimes, rarely?
And this poll is open.
Thank you. So go ahead and get your answers in. Leanne, how are we doing with the responses?
Pretty good. I'm going to give it 10 more seconds.
Perfect. Here's your chance if you haven't responded yet.
And to answer your question, we've got about 90 95 responses, and we're going to go ahead and close the poll.
Fabulous.
We've got a few people in the process of responding, so it's going to be just a few more seconds, and then we'll share those poll results with everyone. Two, 1, 0, and there we go.
Great. So we're back with usually being the most, followed by always, or followed by rarely, and then always and sometimes. And I imagine that a big piece of this is based on just the setting that you work within and your role within that setting. Great, thanks everyone. And so thinking of a person you are serving, kind of reflecting on how did you assess their family-related needs, and what kinds of referrals and services were provided, and how you've addressed these needs in the individual's treatment plan. So if you want to go ahead and kind of type some responses into the chat box. So psychoeducation on substance abuse for parents and family. Great. So I'm going to keep us moving along just so we can make sure to have enough time for questions at the end. So moving along in the continuum, level 4. The counselor provides systematic assessment and planned intervention. So whereas before we're talking about an awareness, we're talking about an openness, we're talking about more of a kind of using empathy and assessing some of the family functioning. In level 4, what really makes a difference is that this is really built into the system. It's built into the intake. It's built into the way that services are provided. And so in order to provide this level of care, we need to have a basic awareness of family systems and family systems theory, which is why we started kind of the webinar with this initial, what are some of the core components of family systems theory and approach. So with that knowledge of family systems, applying that to the family within the greater community system, and being able to effectively engage and intervene with families, including those who might be less than willing to engage with us. And in that engagement, really enhancing the communication and coping. And in this level, there will be some active linkage to specialized family therapy when needed. And so here, I really like to highlight that it can be a lot easier to engage family members who, attend the intake appointment with the person and are calling and kind of giving, updates and asking for resources. The family members who, call us up and say, what can I do to help? And, we give them a referral to Al-Anon, and, a week later they call us up and they say, oh, I attended a meeting and it was so helpful, right? That is so wonderful when it goes that way. And yet very often we may encounter family members who are really burnt out and who have their own kind of clinical needs presenting as they have really experienced distress due to their loved one's substance use. And so what makes level 4 a little bit different is that we can intervene even with those family members who may present as reluctant or disengaged. And that doesn't mean it's 100%, right? There's no intervention that's 100%, but that it's more than just, it goes beyond just intervening with those family members who may be very active in the person's treatment services. And so looking at level 4, when would you say that you are providing this level 4, where you have that systematic assessment of the family included in your assessment of the individual. And then you have some thoughtful and planned intervention around engaging and intervening with the family.
And our poll is open. About 80 responses. Gabrielle, I'm going to give it about 10 more seconds.
Perfect.
I'm going to go ahead and close the poll. We've got a few that are pending coming through now. Three, two, one, and we're sharing the poll results now.
Great. So we see usually and sometimes are the leading categories, and so followed by rarely. So for those who are in the rarely category, I'm curious as to whether this assessment is included in any of your kind of intake assessments, and whether maybe a simple step in the direction of having more family-focused kind of comprehensive services would be just starting with adding an assessment question that might get at some of the family dynamics and family needs. Sometimes it can be kind of that simple. Of course, depending on the background of staff and the orientation of staff, it can be even more enhanced if coupled with some supportive staff training and opportunities for growth. So thanks, everyone. And I'm thinking of a person you're serving, reflecting on how did you assess their family's unique strengths and abilities? What were some of those unique qualities and strengths, and how did you build on those? A lot of times our assessments can be very problem-focused, because at the end of the day, it's those problems that qualify people for our services many times, and yet we miss a very important aspect of eliciting what are the person's unique strengths and abilities, because that's what's going to help them overcome the problem. As we all know, we can't make the change in people's lives for them. If we could, we would, because we love to help, and we're so sincere in our desire to see the people we serve move forward. And yet, we are the catalyst for that growth and that change and providing that support and those resources. But even finding out kind of how the family does respond to problems. How do they overcome hardship? What are something that they'd never want to change about their family? What are they most proud of as a family? And then not just leaving that in the assessment. How do we then help that flow over into the recovery plan or the service plan so that we're still keeping that in sight and truly leveraging those strengths in that person's recovery and in that family's recovery. And then moving into the final level, level 5. So for level 5, the counselor needs to have received training and supervision in order to move to this level of expertise. In this level, the counselor understands family systems and patterns that are typical of dysfunctional families and interacts with professionals in other health systems. So the counselor in level 5 is not only practicing within their own service system, but is also reaching out to those other systems that the family is encountering and helping to helping the family to navigate those systems, as well as helping to kind of coordinate some of the care between those systems. And so in this level, the counselor can handle intense emotions in the family as well as themselves, because we all, of course, have our own history. We have our own experience of family, the good, the bad, and the ugly, right? And so working with families often calls up a lot for ourselves. And we can very easily slip into judgment or scapegoating or, idealizing, right? And at the end of the day, as a counselor, those things, while they're very natural reactions, they're important to notice that they are reactions and not kind of base our counseling services on those reactions. And so here, we see the counselor can handle those intense emotions in families and in themselves and maintain neutrality despite strong pressure to take sides, right? Because family members many times are going to want to kind of push and pull on us, and it'll be very easy for us to slip into kind of taking those sides. The counselor assesses, engages, and intervenes with the family, including family members who are difficult to engage and exhibit poor communication skills. And these are very, like clinical language to say people that are really hard to work with, right? People who don't always show up, people who don't always express their needs or their emotions in ways that are easy to hear, and understanding that part of our role as that family therapist is to be able to see beyond that and see how it's an expression of a symptom that we are there to help the family address. The counselor negotiates collaborative relationships with professionals involved with the family across systems, even when goals may be in conflict. So my goals as the substance use treatment provider, the behavioral health provider, may be a very different goal than the, a probationary entity, for example. But at the same time, really focusing on how we can work together in order to support the client or the family that we're serving and reaching their own goals, and understanding how we all kind of fit into that puzzle together and then generating that collaboration. So thinking about kind of this highest level of family involvement and treatment, where would you put yourself or your organization?
And our poll is open. We've got about 80 responses, and we're going to give it about 10 more seconds.
Perfect.
All right, we're going to go ahead and close the poll and wait for the final responses to process. One, and we are sharing the poll results now.
All right, so we're seeing rarely is the top answer. I imagine that part of that has to do with the way that maybe services are set up within the organization. And so looking at, what are some good referral sources for when you do, how can you assess whether there's a need for this level of integration and treatment services, and who are your referral partners that you can make some really effective referrals to and engaging the family. Followed by sometimes and usually, which is great, and looking at that even, it doesn't mean that every single counselor in a setting has the experience and the expertise in order to provide this level of family integration, but that at least somebody on the team, somebody within the treatment center can provide this service when it's needed, and that you're actively assessing for when this may be needed. And then always, so our family therapists who are here today, thanks for joining us. Thanks, everyone. Those are the ends of our polls today. Oh, you know what? The text on this next slide came out a little bit different than when we uploaded it, but life is always full of tiny surprises, so here we go. So here are some examples for each level of family involvement, and I believe that when the slides get sent out, this text will be dark again. So if you can't fully see it now, when you receive the slides, it'll be available. So some examples for level 1 are informal but carefully thought out and planned. So this can look like speaking with a client's family members while they wait for the client attending a group. Now, of course, we want to keep in mind that, confidentiality, if there's a release of information, what the release indicates, and then not only what we are allowed to share, but what would be relevant to share and what would be okay to share in that public of a setting, like a waiting area. So that might look more like engaging them to invite them back for maybe a family and friends informational session, something that wouldn't be disclosing anything about the person's care. Level 2, an example is providing education or advice to the family in the form of a short discussion, for example, on the stages of substance use and recovery. So stages of change and stages of, just different factors in substance use. Level 3, here we could be educating the family on how substance use affects their parenting and discussing how each parent within the family, if there's more than one parent, could improve their parenting skills as well as supporting them as they make changes. So here we're seeing that psychoeducation, but it's more tailored to the family's needs, and there's more follow-up within that. So there's not only information being delivered, but then a follow-up service and ongoing support. Level 4, here an example might be intervening to define and change the interactional patterns and behavior sequences around substance use, or to determine the exact behavioral sequence associated with substances and establish ways to interrupt that sequence. So for those folks who are able to attend my in-person trainings last week, one of the things we did was creating behavior chains. And a behavior chain helps us see kind of the things that precede the substance use behavior, and then kind of the fallout, what follows after the substance use. Sometimes we also talk about this as the ABCs, the antecedents, the behavior, and then the consequences. So in level 4, we can engage the whole family in behavior chaining to try to unpack how that substance use comes about and what they can do as a family to help interrupt that pattern. And then moving on to the final level, an example here, we might help the family define specific goals for change so that the treatment or the service plan is actually family-based versus individual. And that the goals might or might not focus on substance use. Some of them may include substance use, some of them may be really focused just on the family coping, the family communication, and then helping the family to make those changes. And the focus on level 5 is broader than that at level 4. And so the counselor will often draw on a wider set of skills and approaches to really help the family meet their goals. So some things to consider when we're thinking about what level we should provide. We really want to think about the counselor's level of experience and comfort and really engaging that ethical practice and not practicing outside of our expertise. At the same time, we can always be seeking out, right, continuing education to expand that expertise if it's something that could fall within our role. And then the family's needs and readiness to engage. So both the family circumstances and the counselor abilities are important to take into account. And as we're matching interventions to stage, we might look at if somebody's in more of a recovery attainment, that they're in more of that early recovery. Here we see the family system is unbalanced, but healthy change is possible. Moving along in the recovery adjustment. Here we're seeing the family works on developing and stabilizing the new system. So that's really kind of that active treatment, that active engagement phase. And then going out into that more maintenance or continuing recovery phase, we see here that the family must rebalance and stabilize a new and healthier pattern. So this is moving from the working phase more into what does the family need to do in order to sustain the gains that they've made. Because looking at, of course, that family homeostasis, that families have a big pull in going back to their earlier dynamics. Some things to consider when we would not provide family therapy. So some contraindications for family-based treatment. When not all participants have a voice and can raise issues, the presence of violence, therapy can actually increase this, or extreme anger. And so some of the things we'll be looking at later on after the break is what can we do when an adult does not want or does not consent to having their loved ones involved in their treatment or recovery services. Because I imagine that, you know, our treatment center isn't the only one who sees this happening, right? And then also looking at family-centered recovery supports. The role of recovery support services within recovery-oriented systems of care and long-term recovery is so vital. And so just how we look at recovery supports for the individual, looking at what is needed for the whole family in terms of health, home, purpose, greater community, and then a family-focused recreational activities that help with healthy relationships and parenting. So I'm going to pause and take a little bit of time for questions on the first half.
And just to answer one technical question that has come in, just asked whether or not a copy of the PowerPoint presentation will be made available. And we did make that announcement at the beginning, but just for those of you who may have missed it, we will be providing a PDF version of the PowerPoint presentation. We'll be emailing that to all of the attendees, and it will also be available on the FADA website.
Great. Thank you, Leanne.
And it looks like at this point, I don't have any questions.
Okay, great. So then get ready, save up all those questions for the end of the webinar, and then we'll come back in 5 minutes.
That's right. So I've got 11:04, so about 11:09 or so, we'll start up again.
Great. Thanks, everyone. See you in 5.
And Gabriela, I think we're ready, if you are.
Great. Welcome back, everyone. So moving into effectively engaging families, barriers and strategies. So we're going to start with a case scenario. Luisa. Luisa calls your agency to ask about treatment services. She explains that she recently lost her job and asks about the cost of treatment and whether there is any financial assistance since she also lost her medical coverage. She asks about privacy and confidentiality. While you are explaining that her services would be confidential, she abruptly says, "I don't have anyone to watch my children and I need to get another job. I can't start treatment right now. I have to go," and hangs up. So what are some of the barriers you identify? If folks can go ahead and type into the chat, what are some barriers you identify? And while you're typing and thinking, you can also feel free to respond to what can you do to address the barriers, starting with the very first contact. So financial, yes, definitely a financial barrier. Child care, very common barrier. Support. Yeah. If she doesn't have anyone to help with children, she may have a very small support system. We're also seeing that fear, trust, not having medical coverage, absolutely a barrier. Hope, how we can help inspire hope from that very first contact. You can help set her up with a caseworker and SOAR processing for medical coverage and transportation. Something else that I would be curious about and want to really keep my eyes and ears open in this situation is that, you know, she has a lot of questions about privacy and confidentiality, and then she says, "I have to go," and hangs up abruptly. I would wonder about her safety. Is she maybe dealing with some kind of safety or an intimate partner violence situation, or maybe she would be punished for her substance use issues? We might need to help her safety plan from the first contact. And so what do you do to engage folks who call for services but then appear hesitant? Oh, here's another good response for the barriers. Ask the financial department of your agency if they offer a grant for families in need. Patient could be provided with community resources. Absolutely. All right, so some things that we can do when someone calls for services but then appears hesitant, using our motivational interviewing skills, active listening skills, yeah, I often like to ask people, what is their most important goal right now? What's their most pressing need? And how do they see treatment supporting them and moving towards that goal? Validating their hesitation. Yes, helping people feel heard, seen. But the fact that they called us, right, that can be a really big step for folks. There can be a lot of fear, a lot of concern as people call. And so the fact that we're even hearing from them tells us that they really value their treatment goal. And so how do we help people move forward and kind of step over some of those barriers, some of that fear? Don't pressure them to come in right away. Maybe just give them information, allow them to take their time. If they feel rushed, they may back out. Yeah, so if we're in a later stage of change than the person calling, then we almost drive them to go into an earlier stage of change and kind of back off versus walking alongside them and meeting them where they are. Explaining the process and reassurance, absolutely. That transparency and predictability in our treatment processes is so important for engagement. When I know what to expect, I can really have much more information to help handle my fears. Great, thanks everyone. And so looking at how have you effectively engaged families? Do you use like printed materials? You know, how do you effectively engage families? So some things that we've looked at is during the intake assessment. When we ask individuals during the intake assessment, how would you like your family to be involved in your treatment? They can still say, not at all, and we respect that, of course. But when we even just kind of get the wheels turning of how would I like them to be involved in my treatment? You know, is it just information about the treatment services? Ooh, we have a family support group that run at the same time as the teen groups. I love that. What a great intervention and resource. Psychosocial education, family therapy, targeted case management. Yeah, so often what we can read as ambivalence to treatment may be actually very difficult barriers. And so providing that case management support can really build a lot of early trust as well as effectively engage. Weekly visits. Oh yes, maximizing beginnings and really having that routine contact from the very beginning. Because then when there is a crisis, when there is a need, we've already established that relationship and we've really maximized that beginning and setting the tone of how we're going to work together. And so looking at Looking at another case scenario, those folks who attended my in-person will recognize the case scenario of Kevin. So Kevin is a 22-year-old veteran who recently returned home from his second tour of duty in Iraq. He presents with alcohol and opioid use disorder and PTSD-related symptoms. He's living in his parents' basement and plans to enroll in college. His parents have a history of alcohol use and depression. He has a large social support network made up of both friends and family. So what strengths do you identify in Kevin and his family? As well as what needs? So strong family support network, drive, absolutely. We see that future orientation. He has plans. He wants to enroll in college. He's motivated for education. We also see that Kevin and his family have a need for some information on substance use, as well as social support networks that are recovery-oriented. We see some mental health needs that need to be addressed. And kind of being aware of the family substance use history. Some strengths is he has access to VA services, and he's had success in the past. Military will support each other. It can connect with other soldiers, absolutely. Kind of that the shared history and identity amongst military. Connecting with local veteran groups, a sense of belonging and acceptance. And the friends and social support network may be more of an important focus on recovery instead of kind of the blood relations family. Yeah, that's really sensitive to both Kevin's age as well as his identity as a veteran, that for Kevin, his social support network may be a lot more around his peers. Family education to learn how to help Kevin without enabling unhealthy behaviors. Engaging family through motivational therapy services, veteran support groups, and other social support group services. Yeah, and attending to how he plans to pay for college so it doesn't become another stressor, absolutely. Is he potentially eligible for some different veteran benefits that could help with paying for college? Facilitating his contact with his social support network, staying in touch, right? We know that isolation can be a big problem for individuals experiencing PTSD as well as substance use disorders. Great, thanks everyone. I see Kevin's really reached the right place. I have a lot of hope for Kevin. So family engagement. One of the keys to family engagement is starting early, so beginning that from the very beginning of treatment. And there are some ways we can do that throughout the assessment phase. How could your family and friends assist in your recovery? What would be helpful for your loved ones to know about your treatment and recovery? So here are some open-ended questions that really engage the person in reflecting and considering how they might want their family to be engaged and what impact that might have on their recovery. And this will bring us a lot more information than just like yes, no, do you want your parents to be engaged in your recovery? Do you want your family to be engaged in your recovery? And even if the person says, well, I'm not really sure at this time, you've opened the door to that reflection, and you can always say, okay, well, as you get settled in our services, I'd love to revisit this topic with you and find out, how things are going and how your family can support you or your friends can support you in your recovery process. Psychoeducation as engagement. So setting up some opportunities for psychoeducation. We've had a lot of success recently with putting together some family and friends info sessions. Just having some light refreshments, having a chance for receiving information as well as asking questions. And we encourage the people we serve to attend with their social support. And there's a balance there of providing information with support and resources. We don't necessarily want it to become like a huge group therapy session unless we are planning to have a group therapy session, right? There's a lot of multi-family group therapy sessions that can be really helpful. So really balancing, staying true to that psychoeducation while also creating space for people to share what's important to them, and then being ready to schedule follow-up sessions. So we have all of our counseling staff kind of available towards the beginning of the info session, and a lot of times our clients who are attending with their family members get really excited about introducing kind of their primary counselor to their family or friend, and then having them ready also towards the end of the session. And we end the session with who would like to schedule an individualized family session with a counselor, and really framing it as it's an opportunity to get more specific support, more specific information, as well as we've had people kind of go all the way and say, you know what, I think that therapy for my daughter and I would be really helpful in setting up kind of that family therapy session right there before they leave. So here's a sample session outline that we've used in the past. So having kind of the introduction and welcome, having program description. So starting out with, what are some of the services you provide? Are people even aware of the services that you provide? Of course, during the intake process, there's a whole lot of information that people get, and part of that information, of course, is an orientation to program services, and yet we also know that it's information overload during that time, and that a lot of times people may be experiencing withdrawal or maybe, you know, kind of experiencing some of their own kind of fear about starting treatment. So a lot of that information we provide at the beginning doesn't necessarily stick. And so we've had people, our clients attend our family and friends info session who say, oh, I didn't know I could get family therapy here. And so just starting out even with that program description. And then moving into some general information on substance use disorders and mental health. For us, we provide, if people have co-occurring disorders, we provide integrated treatment. So for us, we provide information on both substance use disorders and mental health. We also make sure to carve out at least 10 minutes for overdose awareness, because we are in the grips of an overdose epidemic, and a lot of the people we serve are at risk for overdose. And so really facilitating their family and friends, having overdose awareness information and providing them with naloxone, because it's much more likely that someone will overdose, you know, within their own kind of natural environment and social support network than necessarily like at our program. Then we focus on how to support your loved one in recovery. And here, you know, we talk about what are some things that to kind of avoid and what are some ways to support. And so really coaching folks on avoiding attempts at controlling someone's behavior. That many times that very control, that, you know, kind of that trauma focus, that a lot of times it's been times in our life where we feel out of control, and the substance use is an attempt to control our feelings, our experience. And so when others try to control us, it can really drive our substance use behavior. And so looking at how can we support without shaming, guilting, and attempting to control. And it's really interesting to see what comes out during this part. I can remember just a couple months ago an individual had brought his sister, and his sister said, you know, I've spent the last 10 years trying to control him and his behavior, and the minute that I said, you know what, like, you have to make this decision, and I'm here to support you, but at the end of the day, you're the only one that can do this, she shared with us, that's when he called me and said that he started coming to your treatment program. And so it's really fascinating to see how people can immediately connect to some of the information that's being shared and really bring it to life. And then of course, engaging the people we serve and finding out what's the best way to get this information out. You have some people who say, you know, I want to take a flyer home and I'm going to put it on the fridge. And I'm going to ask, you know, that my husband, you know, come. So really engaging people and how they want their social supports engaged and what we can do to really support that. And then, of course, surveying the people you serve for kind of what time and what day might work, and then varying the times and days, because people are going to have different work schedules, and then getting a sense of who might attend. So, you know, during the day family and friends info sessions, it's typically going to be adult kind of family members who attend. But during other times, like weekends and what have you, when children aren't in school, sometimes members might want to bring their teenage children to kind of get more information and get support around it. And so adjusting your programming to deliver the appropriate kind of information and the appropriate kind of support based on, like, who's going to be coming. And some essential support services and effective engagement. Recovery support services are so vital for long-term recovery, really the wrap-around holistic support services. And yet what we also know is that they're vital in engagement too, that they can really work in establishing that early trust and making what we have to offer relevant to the person. And so looking at case management. And as we saw in the case of Louisa, you know, it was necessary from the very first contact. And so looking at kind of who is the first point of contact and do they have what they need in order to provide kind of some early resources, or who can they connect the person with to detect and provide those early resources. And really looking at that those who are responsible for the care of children or elders will really need some resources around elder care and child care often in order to engage our services, and that those with children often need assistance in navigating the educational system. You know, my background is in social work and alcohol and drug use counseling, and so as a social worker, I would say, highly trained and experienced in navigating systems, and I still, you know, with my own son trying to navigate the educational system, it can be really confusing at times. And then you layer upon that individuals who may already have so much more that they're trying to navigate and manage in their lives. Care coordination. So we know that women are more likely to experience co-occurring mental and or physical health conditions, as well as be responsible for the care of family, including children. We also know that a lot of the families we serve may have multiple systems involved, whether they're health systems, legal systems, housing providers. They may have a lot of different systems meant to really help support them in their recovery. And yet, for any one of us, having that level of system involvement could be utterly confusing. And so a lot of what we can help families with and that really help their engagement is, I would say, walking alongside them and supporting them in navigating and coordinating all of these systems. And so looking at how we can broaden our perspective and from the beginning kind of reach out, of course, with release of information, reach out to these systems and help coordinate care. Life skills training. So many of the people we serve who, you know, are kind of families in recovery, they may not have had the opportunity or the positive role modeling to develop some pretty important life skills, including money management, home management, and parenting. And that addressing these daily life needs can seem really simple, and yet they can have a really large impact. And a lot of times we can make assumptions around people's life skills, and that when we really assess and kind of take the time to see where someone may be, there's a lot of support that we can provide. And that, you know, especially working with women who may have had substance-exposed infants or who may be involved in child welfare, many times their own parents were also individuals who struggled with alcohol or substance use. And so not only do they not necessarily have the role modeling, but on top of it, they may not have the social support network to really support them in their positive change. And so that said, what are some fun ways that you've incorporated life skill development? So I see here Some fun ways are organizing trips to local parks and zoos. Absolutely. You know, because the last thing we want is to leave people feeling like things are filled with judgment, or like here's just another class that you have to go to because you don't have basic life skills, right? So, but right, when we're talking about life skills, we're talking about daily living skills. So there's so many fun things that we can do to make it compelling and people can learn without feeling like they're being taught. So psychosocial rehabilitation groups, psychosocial education groups, helping them to forget for a few hours, right? When we're talking about recovery, that whole person recovery, a lot of times we're learning about leisure skills, but we're not going to stand up there and lecture someone about leisure skills. We're going to engage them in those leisure skills, like board games, goal setting, groups on the impact of substance use on financing. Oh, here's a fun one, recovery skills hangman with prizes. So literally making games out of it, absolutely. Is there opportunity for us to get really creative with what we're doing? And people respond to that. So thinking about how you can get life skills training, how you can incorporate that in a way that's engaging. You know, adult learners tend to be very experiential. We learn by doing. So, and a lot of people also really like to understand things through stories. So even being able to like read a story together and look at some of the themes together is going to be more fun and maybe have more of an impact for folks. And then recovery coaches. This is an incredibly essential element of recovery-oriented systems of care. And they're such an important resource in helping individuals and families engage in that long-term recovery as well as that early recovery. So a recovery coach is typically somebody with lived experience of recovery. Doesn't have to be, not always, but many times the recovery coach, the expertise they bring is having walked in the shoes of. And they can really act as a bridge between some of the more formal treatment elements, bridging those treatment gains out to the community and the natural environments, and helping the person to develop that wide recovery support network within their natural environment. So in this way, recovery coaches can support overall engagement. They can work to help the person expand their recovery social support, and then can help them practice some of the things they're learning in treatment in places outside of treatment, like their home, at work, in the community. Because we know that the point of treatment is not more treatment. The point of treatment is recovery. And the recovery coach plays such an essential role in really generalizing those treatment gains. Especially looking at how recovery coaches can really attend to the needs of the family. So there are some programs that I've seen that pair recovery coaches with people who are involved with the child welfare system, and the recovery coaches are all people who have, in the past, who are in long-term recovery and who in the past had child welfare involvement within their family. So they're able to really engage and walk alongside in a way that somebody who maybe hasn't had those experiences, it would feel pretty different. And in that vein, the importance of peer support and mutual aid, that kind of the opposite of peer support is isolation. And we know that isolation is something that happens within our disorders. And so peer support and mutual aid, looking at that as a way to engage people, both in early and ongoing recovery. That very often things that people can hear from a peer is very different, and they hear it very different and they receive it very differently than people that they hear it from us as their counselor, right? And one of the things I love about group therapy is that over time, people start showing up, not because of what the counselor is doing or saying, but they're showing up because of their peer support and because of the support and the connections they're having with their peers. And that we know that group cohesion is such an important healing aspect of active group therapy. And so what are some ways that you can facilitate peer support for your families within your organization? Play groups, especially with parents of young children. Oh, absolutely. That is an excellent way to both work on recovery as well as expand that peer network and that recovery-oriented network. Many of the people we serve can feel so alone when they're engaging in their recovery. They can feel so different from people around them. And we also know that a lot of people with young children can also feel very isolated and alone. The play groups, I love that. All right. Oh, taking clients and families to an open AA or Al-Anon meeting. Absolutely. That's a great way to help connect people, especially because for many of us, going somewhere for the first time can be pretty scary. We might not know what to expect. We might not know if we'll be accepted. And so having that support and going there, and then also afterwards kind of debriefing of how it went and how you might continue going. Targeted case managers. So when you don't have the ability to include kind of a recovery coach or peer facilitator, a case manager can help bridge a lot of this through supportive case management and kind of engaging the family. And the school is school-aged. That's great input. Meeting clients at outside meetings and watching them get connected in the community. Absolutely. Have AA, Al-Anon, NA, and NAMI speakers come in and speak at a family group session. What a great way to leverage community resources, right? That if we want folks to be aware of these community resources and use them as part of their continuing recovery plan as they maintain their treatment gains in the community, what a great way to engage them in that, to bring those community partners into your treatment setting. Absolutely. Great, thank you everyone. And then effectively engaging families, it starts with us. So for us, our awareness that families are dynamic, and so treatment must also be dynamic and tailored to wrap around the family. There is no one-size-fits-all. So, you know, we can make the best plans, but also using all of our observation skills and all of our critical thinking skills to be able to be dynamic and flexible and adapt our services to the families we're serving. Conflict is inevitable, but resolvable. So conflict within the family, conflict within the treatment is not a sign of failure. It doesn't mean that it's not going well. I remember we hosted a recovery community meeting for the clients in our care, and there was a very high level of conflict that happened. And that, you know, it would have been very easy to walk away from that and go, oh, well, that was a mistake. But actually, the way we were able to look at it was that, wow, that tells us that it was really important to have a recovery community meeting and that we need to have many more of those to really work through these conflicts, and that we probably need more structure in helping to coach individuals to work through those conflicts. Right? Because conflict doesn't just happen in the treatment center. Conflict is a part of life. And so knowing how to resolve them, building skills to resolve conflict is a vital part of our treatment. And that when we have diverse multidisciplinary teams who create a collaborative environment of mutual respect and cross-training, then we will have the ability to serve so many more people and to serve them holistically. So when we can have teams that are made up of, you know, child welfare specialists and treatment specialists and family therapy specialists and, you know, mental health specialists, and that it's and that understanding that we may have different frameworks, we may have different jargon that we use, we may have different kind of thoughts on how to define and approach the problems and the needs of the client or the family, but to approach all of that with awareness, with mutual respect, with a collaborative versus competitive approach, and then engage in that cross-training. So, okay, maybe the dedicated substance use specialist isn't going to be the one who is providing the family therapy, but let's set up opportunities for them to have an understanding of family dynamics. And maybe the family therapist isn't the one who's providing the integrated care on the, you know, recovery coaching, but let's make sure that they're aware of the role of the recovery coach and how the recovery coach is a vital aspect of that multidisciplinary team. Which brings us to our final topic, which is CRAFT. CRAFT stands for Community Reinforcement and Family Training Therapy. And so something that is really fascinating about CRAFT is that it actually intervenes with the social supports of the person who is using substances rather than the person themselves. And so what it does is that it empowers the concerned social supports to help address the substance use issues of their loved one without using classic approaches that are either detachment-based or confrontation-based interventions. Now that said, I will say that Al-Anon is still an absolutely important resource for many families and individuals, and it's very different from CRAFT. So whereas Al-Anon is really a peer mutual support where people can find a lot of connection and help kind of develop some of those healthier boundaries and expectations that help them continue to kind of support their loved one. CRAFT is focused more on engaging the loved one in treatment. So the studies have found that 2/3 of the loved ones so let me see how I can phrase this. 2/3 of the people who engaged in CRAFT, their loved ones entered treatment with only the intervening of their significant social support. So CRAFT really focuses on helping the social support to engage their loved one in treatment without the use of confrontation. So it's a brief therapy. It's usually 12 to 14 60-minute sessions. The first month it's going to be twice a week, and then for the following 6 or so weeks it's going to be once a week. So CRAFT has 3 main goals. It helps the concerned social support move their loved one towards treatment, and that's where that outcome of 2/3 of the individuals did enter treatment. It helps reduce their loved one's alcohol and drug use, whether or not their loved one has engaged in treatment yet. And finally, it improves the lives of concerned family and friends, because we know that there is a large clinical need by the people who are very concerned about their loved one's substance use, right? Many times this experience of trying to support someone in their recovery can be really, there's a lot of clinical need there. We can feel really lost in how to help someone. So the core strategies. The first thing, of course, is screening for the presence of violence, including emotional abuse. And if violence is present, you know, if I would say physical violence, intense violence is present, then CRAFT is probably not the right intervention to use. That said, we may still have the opportunity to safety plan. And if there is emotional abuse that is more focused around the substance use episodes, then CRAFT can still be effective. The second thing we want to do is collect information from the loved one on the person's pattern of use. So here we're really trying to get a sense, again, of those ABCs, of the antecedents, behavior, consequences, of the behavior chain, of what are all the things that kind of lead up to the use itself, you know, frequency, duration, amount, where they're using, kind of what their mindset is in using, as well as the consequences of use. We want to find out what the person likes about their use. So what I mean here is asking the loved one what they believe the person using substances gets out of using or wants to get out of using, as well as what they don't like about using. Ultimately, creating some hypotheses around what is motivating the alcohol or substance use. The third step, then, is focusing a plan on increasing non-use behaviors and decreasing use behaviors. And so here we're really coaching the individual, the loved one, on learning to encourage the non-use or lessened use behavior, and then effectively discouraging the use behavior without using attempts to control, shame, or blame. So something to keep in mind here is that if negative emotions were effective in reducing use, we likely wouldn't be meeting the person because they would have already tried this and it would have already worked. Sometimes, you know, the control, shame, and blame is effective in changing someone's use patterns, and that's where we also see that the vast majority of people with risky alcohol and substance use spontaneously recover without ever entering formal treatment or coming into contact with a formal treatment provider. We also see a lot of people, you know, age out of their risky alcohol and substance use. So we have to keep in mind that when somebody is coming to us for help, it's likely because that control, shame, and blame has not worked. And so in many ways, we coach the person on saving all of those negative emotions, because it's very natural to have those negative emotions, to save those for their counseling sessions, to bring that to the counselor rather than taking it to the person who is using the alcohol or substances. Something else we can counsel folks on doing is to kind of write it all out, you know, everything that they're feeling, all the negative emotions they're having, to write it all out on a piece of paper and then tear up that piece of paper into 100 pieces. You know, so if they feel like they're not going to hold on to it for their next counseling session, that's something else they can do. And then the next step in CRAFT is increasing that self-care and nurturing behavior. So really helping the social support to learn to have fun again, to not lose sight of relationships, to continue nurturing their connections, and to refill their cup, right? We can't pour from an empty cup. So we need to refill our reservoirs in order to continue showing up and supporting our loved ones, including the person who's using. So CRAFT is behavioral, and it's focused on behaviors and motivation. So it teaches the family and concerned social support to understand a loved one's triggers for use, positive communication, positive reinforcement, so rewarding the non-use behavior, problem solving, self-care, safety planning, and techniques for getting a loved one to accept help that are not focused on control, shame, or blame. Here are some different session topics that are included in CRAFT. So reconnecting with the person's positive characteristics, especially those that predated the substance use, increasing safety around potentially dangerous situations, positively reinforcing activities that do not involve use or have lessened use. So this might be something like, if we know that the person is less likely to use when they're engaged in, you know, let's say family activities with extended family, then let's go ahead and plan more family activities with extended family. Let's plan some visits with extended family. Let's plan some routine, phone calls and connections with extended family. If we know that, for example, they're less likely to use when they're bike riding and they really enjoy bike riding, well, then let's plan a routine around bike riding where we, go out, have a light breakfast and go out for a long bike ride every Sunday, right? So really kind of building in some structure around how and when we notice a person either does not use or has lessened use. And then a non-confrontational, non-reinforcement of substance use, largely by ignoring or avoiding the person when they are using substances. So not kind of engaging in the drama around the substance use, but for example, we might say, okay, this person really enjoys having, Sunday brunch with the family. So if they wake up Sunday morning and they've been drinking, to be able to very calmly say, okay, I can see that you've started drinking, and so instead of having our family brunch we had planned, I'm going to take the children out, and you can take care of yourself and your day, and we'll be back this afternoon. And to do that in a way that is even keel, that is matter of fact, and is just non-reinforcing the substance use. And of course that takes a lot of coaching, right? A lot of practice. And then using non-judgmental, non-shaming, non-blaming communication. Discontinuing communication that does not have a positive impact on the person. So having a sense of how what we're doing is impacting. Are we seeing the results that we hope to see with this communication style? And then expressing those negative thoughts and feelings with the therapist rather than at the person who is using substances. And then finally, that self-care, as well as engaging the person in substance treatment during those windows of opportunity. We often see these windows start to open, and really knowing that when these windows of opportunity for treatment acceptance open, really striking when the iron is hot. And so this style can be pretty different than some of the other more classical approaches or some of the things that people have tried, and yet when we're doing behavioral therapy, many times we'll hear from folks like, oh, this doesn't feel right, this doesn't feel like genuine for me. And to be able to know that if we want different results, we have to be willing to try out some things that are different. And knowing that as we practice behaviors, they become more natural and more routine for us. And that a big part of what we're doing in recovery is practicing new behaviors and almost behaving our way into new ways of thinking. So with that, we have come up to our question and answer. I only have about 4 minutes left for question and answer, but I'd love to take any questions that folks have held on to.
I see one, Gabriela. Or yes, is there a specific screening tool for the presence of violence when using craft?
That's a great question. There's not a specific screening tool, so I would suggest using open-ended questions, questions you might normally use. It's always better to describe what you're asking for rather than use a label. Because, for example, I may not identify as someone who, is experiencing domestic violence, but if someone were to ask me as a hypothetical client, has your partner ever used physical force to, restrain or, touch you in a way that resulted in an injury, I might be more likely to say yes, because then it's not about a label that I interpret as domestic violence or not. And so I would say there's some really great guidelines around screening for intimate partner violence and violence in the home, available through some domestic violence networks, and so to consult those.
Thank you. And then we have one other, whether or not craft works best with any particular ethnicities, or if there's been any studies done around craft and its use with various ethnicities.
You know, off the top of my head, that's such an important question. Thank you. Off the top of my head, I don't remember the specific studies, what the population demographics were, but I'm going to go back. Let's see. At the bottom of these screens, it came out in this like light pink writing, but I think when you go, when you get the actual slides, this link here at the bottom should be a little easier to read. But if you go to SAMHSA's National Registry for Evidence-Based Practice, nrep.samhsa.gov, they have a whole breakdown of craft and all of the experimental studies on craft. And I love this website because it will absolutely unpack all of the population demographics, all of the measurements they used, and it really helps you assess the statistical significance as well as the practical significance of the intervention. Great question.
Okay, thank you. And we have time for one final question, then we've got to wrap up. It says, can family members attend your family events, information events, before they have a loved one in your agency?
That's a great question. So absolutely. What you would want to do is set up a separate family and friends info session. It might just be an info session in general for people who are interested or kind of prospective or just community members, and have that session be slightly different. They might even be, you know, the same day, just different times, but have that session be different than the ones who are active in treatment. So if the people who are active in treatment want to ask more specific questions or questions that might identify them as a member of the treatment, that their confidentiality is still protected.
Wonderful.
So thank you so much, everyone. It's been so great to speak with you today, and feel free to reach out to me. I'd love to hear how you use any of these materials.
And Gabriela, if you're ready, I'm going to take control back of the presentation.
Absolutely. Thank you, Leanne.
Thank you again, Gabriela. I do want to remind everyone who may have missed out at the beginning of today's presentation, when I conclude today's webinar, your browser is going to take you to an evaluation on FADA's new website. If you want to receive continuing education credits or a statement of credit for this event, please do complete the evaluation for us. You may be prompted, in fact, you will be prompted to register or log in to complete the evaluation, and you can certainly register as a visitor. For credits to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide us with an accurate Florida Department of Health license prefix and a number at least the first time that you register with us. After you register or sign in, you'll be directed onward to the evaluation. You may consider using the same email address when you register for webinars through our WebEx link and when you set up your profile in FADA's system, and this helps us connect your attendance with your profile. You will get a second opportunity to complete the evaluation, so if you have to run, do note that you will get an email from us in about 30 minutes, and do remember that the evaluation closes at midnight on Monday, April 16th. This is, you will be notified when the statement of credit has been issued in your profile, and you will get that notification from this email address on your screen right now. So finally, I just want to say thank you, Gabriela, again for today's wonderful presentation and sharing your very comprehensive expertise with us. We very much appreciate it. And I'd also like to thank all of our attendees today for participating in the webinar. And of course, we would also like to recognize and thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. So to everyone, have a great rest of your day, and please hold now for the evaluation. Thank you so much.